Cardiovascular physiology. So an overview of the cardiovascular system, much of this should be a review from general E&P, but cardiology is the study of the heart and its disorders. Cardiovascular system consists of the heart blood vessels. The heart is a pump that keeps blood flowing through the vessels. Vessels deliver blood to body tissues and returns it to the heart. Arteries, all vessels that carry blood away from the heart. Veins are the vessels that carry blood toward the heart. And capillaries are microscopic vessels that connect the smallest arteries to the smallest veins. That's where the majority of fluids and gas exchange occurs. The circulatory system refers to the heart vessels and blood that circulates not only oxygen, carbon dioxide, but also nutrients and wastes around the body. Cardiovascular system has two major divisions: the pulmonary circuit, which carries blood to the lungs for gas exchange and back to the heart, and then the systemic circuit, which supplies oxygenated blood to all the tissues of the body and returns it to the heart. The right side of the heart supplies blood to the pulmonary circuit. Oxygen-poor blood arrives from body tissues, and then it's sent to the lungs to go pick up oxygen, and is returned to the heart through those pulmonary veins. The left side of the heart pumps blood to the systemic circuit, so to the rest of the body. Fully oxygenated blood is sent to body tissues via the aorta, which branches into smaller vessels, and blood releases oxygen at the tissues. Deoxygenated blood returns to the heart by the superior vena cava and inferior vena cava. So this is just a review of the pathway of blood flow through the heart. So deoxygenated blood comes in to the right side of the heart. And remember, we always put ourselves in anatomical position, so this is going to be the right side of the heart over here when we're looking at the front view of the heart. So on the right side of the heart, deoxygenated blood comes in. It's going to go through this right AV valve and then out to the lungs to go get oxygen. In the lungs, there's going to be some gas exchange. Carbon dioxide leaves the blood, oxygen enters the blood, and then it comes back to the heart through these pulmonary veins. Comes into the left side, and then the left side of the heart will then pump the blood out to the rest of the body. The left side of the heart muscle is a lot thicker. So even though the heart itself lies directly in the center of the chest, right underneath the sternum, which is that main bone in the center of our chest, the left side of the heart is slightly enlarged and is a little bit thicker because it has to have this strong muscle to pump blood to the rest of the body. The right side is just pumping blood to the lungs. Well, the left side has to get it all to the rest of the body, so it's a little bit thicker and a little bit larger. The heart itself is an organ, and the heart muscle itself needs its own oxygen supply and nutrient supply. So the heart has its own supply of blood vessels that deliver blood to the myocardium, or the heart muscle tissue. This is known as coronary circulation. Arterial supply, so from the artery side of things, the left coronary artery branches off the ascending aorta. The anterior interventricular branch supplies blood to both ventricles and the anterior 2/3 of the anterior ventricle septum. The circumflex branch passes around the left side of the heart in the coronary sulcus, and it gives off left marginal branch and then ends on the posterior side of the heart. It supplies the left atrium and posterior wall of the left ventricle. The right coronary artery branches off the ascending aorta. The right marginal branch supplies the lateral aspect of the right atrium and ventricle. The posterior interventricular branch supplies blood to the posterior walls of both ventricles and interventricular septum. Flow through the coronary arteries is greatest when the heart relaxes. During ventricular contraction, the coronary arteries are compressed. Open aortic valve blocks the blood flow to them. During ventricular relaxation, the blood in the aorta surges back toward the heart and into the openings of the coronary arteries. So this is a picture of those coronary arteries here. You should be familiar with how they branch and which parts of the body or which parts of the heart they serve. These are so incredibly important because if they get blocked, and the region where they get blocked, that's a heart attack. And the region where they get blocked, that determines the extent of damage and whether someone lives or dies after a heart attack. And we'll talk more about heart attacks in just a little bit. but be familiar with the locations of these coronary arteries. And then on the back side of the heart, you can see the other branches. And here is with the heart removed, what it would look like. All right, angina and heart attack. So angina pectoris is chest pain. Chest pain from partial obstruction of coronary blood flow. The pain is caused by ischemia of cardiac muscle, or the constriction of the cardiac muscle. Obstruction partially blocks blood flow. The myocardium shifts to anaerobic fermentation, producing lactate, and that stimulates pain. A myocardial infarction is sudden death of a patch of myocardium resulting from long-term obstruction of the coronary circulation. Atheroma, blood clot, or fatty deposit often obstructs coronary arteries. Cardiac muscle downstream of the back blockage dies. Heavy pressure or squeezing pain radiating into the left arm. Some painless heart attacks may disrupt electrical conduction pathways, leading to fibrillation and cardiac arrest. Venous drainage. So that's how blood goes from the heart back inside of the heart. So from the heart muscle tissue on the outside back to the inside of the heart. 5 to 10% of coronary blood drains directly into the heart chambers, mostly the right ventricle by way of small cardiac veins. Most coronary blood returns to the right atrium by the great cardiac vein, blood from the anterior aspect of the heart, the posterior interventricular or middle cardiac vein, blood from the posterior aspect of the heart. Left marginal vein travels from apex up the left margin of the heart. Coronary sinus, transverse vein in the coronary sulcus on the posterior heart, receives blood from veins lifted above, empties into the right atrium. Heartbeat is myogenic. Signal originates in the heart itself. Heart is autorhythmic, has built-in pacemaker and electrical system, so it does not rely on nervous system for its rhythm. The heart is composed of cardiac muscle, striated like skeletal muscle, but many different features. Cardiomyocytes are striated, short, thick branched muscle cells. One central nucleus surrounded by light-staining mass of glycogen, sarcoplasmic reticulum, and lax terminal cisterns, or large T-tubules. Going back to here about the heart being autorhythmic, cardiomyocytes, when isolated in a petri dish, will continue to pump or beat on their own. And then if you put another cardiomyocyte next to it, then they will start pumping in unison. So part of my research at UW-Madison, I was investigating ion channels in the heart, and we were able to isolate some of the actual heart muscle cells and put them in dishes, and you can see them beating independently, and if you were to put them next to each other, they would then beat together in unison. Really cool phenomenon, and if I can find a video, I will definitely post a supplementary video on that. Intercalated discs, those are the connections between cardiomyocytes, and they contain interdigitating folds, mechanical junctions, and electrical junctions. Interdigitating folds, membranes of cells folded to lock cells together and increase surface area of contact. Mechanical junctions, fascia, adherens, broad band, in which the actin of the thin myofilaments is anchored to the plasma membrane, cells linked by transmembrane proteins. And then desmosomes, those are the mechanical linkages that prevent contracting cardiomyocytes from being pulled apart from each other. They are electrical junctions. Those are the gap junctions that allow to flow, or ions to flow between cells. And the cells stimulate neighbors and contract in unison. So we have these intercalated discs with these gap junctions to allow for the rapid passage of electrical signal. Once the signal starts in one part of the heart, it has to spread very quickly to the rest of the cells in that part of the heart so that they can all be stimulated to contract in unison. So here you can see cardiac muscle tissue. This should be a review if you learned about tissues in general E&P, but these are the intercalating discs, and that's how those cardiomyocytes are going to be connected. And here is kind of a cartoon drawing of the intercalated discs, and you can see the gap junctions and desmosomes that hold everything together. Cardiac muscle depends almost exclusively on aerobic respiration to make ATP. They're rich in myoglobin and glycogen. Myoglobin helps to hold oxygen. Glycogen is our store for sugar, so we can break glycogen down to release glucose into the muscle to be used for ATP production. Huge mitochondria, they fill about 25% of the cell, and they're fatigue resistant because it makes little use of anaerobic fermentation or oxygen depth mechanisms. It doesn't fatigue for a full lifetime. Cardiac muscle is adaptable to different organic fuels. So fatty acids, 60%, glucose, 35%, ketones, lactate, and amino acids, 5%. They're more vulnerable to oxygen deficiency than the lack of a specific fuel. So when we talk about the cardiac conduction system and what makes the heart beat, the cardiac conduction system coordinates the heartbeat. It consists of an internal pacemaker and nerve-like connection pathways through the myocardium, generates and conducts rhythmic electrical signals in the following order. So we start with the sinoatrial node. I'm going to go to the picture, and I'm kind of going to bounce back and forth between the picture and the description. So here is the SA node, or the sinoatrial node. This is known as the pacemaker of the heart. Without any stimulation at all, this will stimulate an action potential all by itself. So that's what's known as being autorhythmic. So this is going to initiate a heartbeat all by itself. Now, outside stimuli can stimulate this thing to increase its firing or decrease its firing. Or sorry, not decrease its firing, go back to kind of normal firing. So it can stimulate to be increased or stimulate to kind of slowly go back down to normal. So the sinoatrial node, that's the patch of modified cardiomyocytes in the right atrium, which serves as the pacemaker and initiates each heartbeat that determines the heart rate. The signals then spread through the atria. So once this thing is stimulated, the signal is going to pass through the gap junctions, intercalated discs, and the myocytes in both atria. What the goal is to have the atria pump blood down to the ventricles. So step one, we're going to stimulate the atria to contract, and then that's going to pump blood down to the ventricles. Then we have the AV valve, or the AV node, atrioventricular node, the patch of modified cardiomyocytes that serves as the electrical gateway through to the ventricles. Fibrous skeleton prevents signals from passing to the ventricles by any other route. So here is that AV node, and there is a pause before this one fires. So the signal is going to spread down, it's going to spread to both atria, and then there's a pause, and then this one will fire and eventually spread down into these left and right bundle branches, and then to the Purkinje fibers, or the rest of the heart. The AV bundle pathway from which the signal leaves the AV node forks into the right and left bundle branches that travel through the interventricular septum. The subendocardial branches, also known as Purkinje fibers, processes arising from the lower end of the bundle branches branch extensively through the ventricular myocardium. Once signals reach the end of the conduction system, they are perpetuated by cardiomyocytes via gap junctions. And here you can go. Once we've got down here, we're going to go into the right and left branches and eventually up into those Purkinje fibers. So you should be familiar with the pathway through this cardiac conduction system. The heart cycles through contraction and relaxation. Contraction is called systole. Relaxation is called diastole, also known as diastole and systole. These terms can refer to the contraction and relaxation of either type of chamber. They usually refer to the action of the ventricles. Sinus rhythm is a normal heartbeat that's triggered by the SA node. In adult at rest, it's typically between 70 to 80 beats per minute. Ectopic focus, a region of spontaneous firing other than the SA node. It may govern the heart rhythm if the SA node is damaged. Nodal junctional rhythm, if the SA node is damaged, the heart rate is set by the AV node, 40 to 50 beats per minute. Other ectopic foci fire at rates 20 to 40 beats per minute, which is too slow to sustain life, so that's when a pacemaker may be needed. The SA node fires spontaneously at regular intervals. The mechanism: the SA node does not have a stable resting membrane potential. It starts at minus 60 millivolts and drifts upward due to the slow sodium inflow. Gradual depolarization is the pacemaker potential or pre-potential. When it reaches a threshold of minus 40 millivolts, voltage-gated potassium channels open and potassium leaves the cell, causing repolarization. Once potassium channels close, the pacemaker potential starts over. When the SA node fires, it sets off the heartbeat. As the internal pacemaker, it fires every 0.8 seconds, setting the resting rate at 75 beats per minute. So here you can see the slow inflow of sodium, threshold is met. You have sodium inflow, potassium outflow, back to resetting it, and back to the pacemaker potential. And it just kind of continues going in this pattern. Impulse conduction to the myocardium. So the signal from the SA node stimulates the atria to contract almost simultaneously, reaches the AV node in 50 milliseconds. The signal slows down through the AV node due to thin cardiomyocytes with fewer gap junctions, delays the signal 100 milliseconds or 0.1 seconds, which allows the ventricles time to fill. So we want to push the fluid down from the top into the bottom of the heart. We want to make sure that all of the blood is down in the bottom of the heart before we then contract the bottom of the heart. So we have to have this pause to allow for the blood to go from the atria all the way down into the ventricles. If we don't pause, imagine you have a sponge and imagine that there's a spill on the ground. Now you put that sponge on top of the spill and you set it down on top, give it a chance to soak up the liquid, and then lift up the liquid. Well, now you've got the liquid inside of the sponge. Now imagine pushing the sponge down into the liquid and continuously pumping the sponge. Liquid is just going to be sloshing around all over the place. It's not actually going to absorb up into the sponge. So we have to give the ventricles a chance to fill before expelling the blood from the heart, because otherwise blood is just going to be sloshed around inside of the heart without actually going anywhere. So that delay is necessary, which allows the ventricles time to fill, and then the signal travels very quickly through the AV bundle and subendothelial conducting network. Entire ventricle myocardium depolarizes and contracts in near unison. Ventricular systole progresses up from the apex of the heart. The spiral arrangement of the myocardium twists ventricles slightly, like someone wringing out a towel. Action potentials of cardiomyocytes differ from those of nodal cells, neurons, and muscle fibers. Cardiomyocytes have a stable resting potential of minus 90 millivolts and depolarize only when stimulated. Depolarization: the stimulus opens voltage-regulated sodium gates. Sodium rushes in. Sodium gates close quickly, and then calcium channels open and calcium enters. Then plateau: voltage-gated slow calcium channels open and calcium enters on the sarcoplasmic reticulum. Lasts about 200 to 250 milliseconds, which sustains a contraction for the expulsion of blood from the heart. Then you have repolarization. Calcium channels close, potassium channels open. Potassium leaves the cell, returning it to resting potential. Cardiac muscle has a long absolute refractory period of 250 milliseconds, compared to 1 to 2 milliseconds in skeletal muscle. Prevents wave summation and tetanus that would stop the pumping action of the heart. So this shows the action potential of a ventricular cardiomyocyte. And the steps are listed out here, which is a review of just what I just went over. The electrocardiogram, so detect electrical currents in the heart using electrodes or leads on the skin, and the electrocardiograph to amplify and record the signals. The record is called an electrocardiogram, ECG, or EKG. A composite of all action potentials of a nodal and myocardial cells are detected. So this is the normal ECG. It's EKG if it's spoken, ECG if it's written. We have a P wave, the QRS complex, followed by the T wave. The P wave indicates atrial depolarization. In other words, that's when the signal is spreading through the atria. Shortly following the P wave, we have the contraction of the atria. So atrial systole happens right within this time frame. Then we have the QRS complex. So before we get to the QRS complex, we have this PR, or the P to Q interval is sometimes what we call it. But the PR interval, the signal conduction through the AV node before activating the ventricles. Then we hit the QT interval. The QT interval is the duration of ventricular depolarization, which is shorter during exercise. The QRS, atrial repolarization and diastole, repolarization concealed by the QRS wave. So now we have the QRS complex happening, and then the PQ segment from P to Q in here. Signal conduction from the SA node to the AV node, atrial systole begins. In the ST segment, ventricular systole and ejection of the blood corresponds to the plateau of the cardiomyocyte action potential. So kind of going through a typical wave here. As I mentioned, the first thing that's going to happen is the SA node is going to fire. When the SA node fires, that electrical conduction through the atria is picked up by the P wave. That electrical conduction through the atria is going to cause the atria to contract. So now we're having atrial systole. So the blood is being pushed down to the bottom, to the ventricles. So now we're going to have a 0.1 second pause at the AV node. And we're going to pause there to allow for the ventricles to finish filling. Then we have this QRS complex. The QRS is formed when the ventricles start to depolarize. So now the signal, the AV node fires, and the signal is now being transmitted through the ventricles. During that time, the heart is going back to, the atria of the heart is relaxing. So that's going through diastole, but the ventricles are contracting. So they're going to start going through systole. And because the ventricle systole, or the electrical conduction through the ventricles, is so strong, it masks the atrial diastole. Then you're going to have the ventricles relax. So ventricular diastole, that's this T wave. And then this is just going to continue throughout the normal QRS, EKG. So this kind of writes out that summary that I just gave. The P wave depolarized the atria. Atrial systole begins 100 milliseconds after the start of the P wave. The PQ segment between the P and Q deflections represents the time for the signal to pass from the SA node to the AV node. QRS complex, that's depolarization of the ventricles. Ventricular systole begins shortly after. The ST segment is between the S and T deflections. That's the time the ventricles are contracting. Then atrial repolarization also occurs, but it's a weak signal and it's obscured. T wave repolarization of the ventricles immediately prior to diastole, so right as they're starting to relax. So if we were to relate the ECG to what's actually happening in the heart, the atria begin depolarizing and they're going to produce that P wave, and then the atria are going to contract to produce the end of the P wave and that P to Q complex. Then ventricular depolarization begins. Then you have the signal starting to spread through the ventricles, and then you're going to form that QR complex, and the ventricles are going to start to contract. So that is the RS complex here. Then the ventricular repolarization begins, so that's going to make the T wave, and the ventricles are eventually going to relax, and ventricular repolarization is going to be complete, and that produces this. So no matter how many times you watch videos and you hear someone talk about this whole cycle of the cardiac cycle, the electrical conduction system, what's actually happening in the heart during the EKG, no matter how many times you all put that together, it's going to take you putting in the effort and studying and actually drawing your own diagrams of the individual processes. So I've provided a lot of resources that go with this, the assignment series for this section. Take your time using those resources. This is going to unfortunately be time consuming because there's no way to really get you to understand it until you understand it. And I'm sure that's really confusing. But you have to put in the time to picture how this is all going together, because memorizing a series of steps isn't going to help you. Memorizing a picture isn't going to help you. It's a matter of being able to be like, oh, systole is contraction. Oh, we're having electrical signal come through here. We have deep polarization followed by repolarization, and what's happening with the atria when this is happening, or what's happening with the ventricles when this is happening. So being able to picture this and put it all together is complicated, but it's time consuming. So fortunately, to get this whole portion, you're going to have to put in the time to try to use those tools and understand it. So deviations from the ECG can indicate a myocardial infarction. Abnormalities in the conduction pathways, heart enlargement, and electrolyte and hormone imbalances. Examples: ventricular fibrillation. Random electrical signals result in no pumping action, hallmark of myocardial infarction, and quickly fatal. Atrial fibrillation. Weak rippling contraction in the atria due to chaotic signals. Atria fail to stimulate the ventricles. So when we talk about fibrillation is basically like squishing a sponge really fast. And I gave that example earlier, but if you put a sponge on some liquid that's spilled and you just kind of squish back and forth really fast and kind of pump your hand on top of it really fast, you're just sloshing liquid all over the place. That's kind of what happens in the heart during fibrillation. Atrial fibrillation, sure, that's bad. We never want fibrillation in the heart, but it's not necessarily going to kill you. And atrial fibrillation can be due to a whole bunch of different reasons. But ventricular fibrillation, so like if you think about gravity in the body, if the atria are contracting kind of weird, blood is naturally going to go down into the ventricles by gravity anyways. It's just going to go into the ventricles a lot less efficiently. But with ventricles, if the ventricles start doing that, they are not able to properly push the amount of blood out of the heart to the rest of the body. Now that one can kill people because we need to get the blood out of the heart. And that's actually going against gravity because now we're in the bottom part of the heart and we have to push it up and out of the heart. So ventricular fibrillation is fatal because that's pumping blood to the rest of the body, including the brain, including the heart itself. And if we have that failure, then that can be fatal. A heart block is a failure of part of the conduction system, include bundle branch block, bundle branch failure, or total heart block, AV node failure. Some people can be born with certain blockages in this conduction system, and then they just reroute throughout their lifetime and they can still have a normal functioning heart. It is detected on an EKG, but it's not life-threatening, and it's just something we kind of are aware of for that particular patient. Premature ventricular contraction, ventricular ectopic focus fires and sets off an extra beat. So this is a picture of ventricular fibrillation. So if that is ever seen on an EKG, that is an emergency situation. Now, something I do want to mention, if you go to the hospital and they put the leads on you, they put the little sticky pads all over your body and they set up the leads. If you are moving, the leads can get disrupted and sometimes these patterns can form. So they want to see at least 10 abnormal waves in a row. So if you have normal, 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 and then all of a sudden it's like this random, like yucky pattern like this, and then it goes back to normal, it's probably because you moved. And that can set a lot of panic if someone is actually paying attention to their own EKG. Not saying that's ever happened to me, but it's happened to me. Watching my dad's EKG and like freaking out about it. So atrial fibrillation looks like this. A heart block, you can see, would look like that. And then premature ventricular contraction, random heartbeat, causes the ventricles to contract. Blood flow, heart sounds, and the cardiac cycle. So now kind of putting it all together. A cardiac cycle is one complete contraction and relaxation of all four chambers of the heart. Remember, the two top ones contract at the same time and the two bottom ones contract at the same time. Questions to consider: how do pressure changes affect blood flow? And how are the heart sounds produced? So two main principles or variables govern fluid movement. Pressure, which causes flow and resistance, opposes it. Blood pressure is measured with a sphygmomanometer. Flow requires a pressure gradient, difference in pressure between 2 points. Fluid flows from high pressure point to low pressure point. Inverse relationship between volume and pressure. So the higher the volume, the lower the pressure. The lower the volume, the higher the pressure. Let's think about this with a practical application. If you have a water hose, and there's no nozzle on the end, you're just letting it freely flow out of the hose. Now, if you put your thumb over the end of the hose, what you have done is you have decreased the volume that the water has to go through. And that increases the pressure, causing the water to spurt out really far. So if we want water to go farther, we decrease the volume of the hose. And that's kind of what we do when we talk about volume and pressure changes in blood pressure. So if we want to have a higher blood pressure, we can constrict our blood vessels, and that's going to cause the blood to be more pressurized. If we need a lower blood pressure, we're going to dilate those blood vessels, and that causes the blood to be less pressurized. And this is a picture. We actually have a device like this in the classroom, which we will work with during an in-person lab if we have that opportunity. So events occurring on the left side of the heart: when the ventricle relaxes and expands, its internal pressure falls. If the mitral valve is open, blood flows into the left ventricle. When the ventricle contracts, internal pressure rises, and then the AV valves close, the aortic valve is pushed open, and blood flows into the aorta from the left ventricle. Opening and closing of the valves are governed by these pressure changes. AV valves limp when the ventricles are relaxed. Semilunar valves are under pressure from the blood in the vessels when ventricles are relaxed. So this just diagrams what we just talked about. And here, when the semilunar valves are open versus closed. Valvular insufficiency or incompetence is any failure of the valve to prevent reflux or regurgitation, the backward flow of blood. Valvular stenosis: cups are stiffened and the opening is constricted by scar tissue. Regurgitation can be heard as a heart murmur. Stenosis, people can be born with. There is an operation that can try to correct some of the damage of the stenosis. Mitral valve prolapse is insufficiency in which one or both mitral valve cusps bulge into the atria during ventricular contraction. And those can be heard when we auscultate the heart. The entire cardiac cycle is complete in less than 1 second, and the phases of the cardiac cycle are as follows: ventricular filling, isovolumetric contraction, ventricular ejection, isovolumetric relaxation. So we're going to talk about what's happening during each one of these stages. First, ventricular filling. The ventricles are going to expand and their pressure drops below that of the atria. AV valves open and the blood flows into the ventricles. Filling occurs in 3 phases: rapid ventricular filling, which is the first third; diastasis, which is the second third; slower filling, the P wave occurs at the end of the diastasis; and atrial systole, final 1/3, the atria actually contract and push the blood down. Remember, we're typically operating with gravity. If we are in an upright position, blood is going to go from the top part of the heart down to the bottom part of the heart a lot by gravity. The end diastolic volume remains in each ventricle, and it's about 130 mils of blood. Then we have the isovolumetric contraction. Atria repolarize, relax, and remain in diastole or diastole for the rest of the cardiac cycle. The ventricles depolarizing causes the QRS complex and begin to contract. AV valves close as the ventricular blood surges back against the cusps. Heart sound, S1, occurs at the beginning of this phase. That's due to the closing of the AV valves. So our heart sounds that we hear, the dung dung, dung dung, that first sound is the closing of the AV valves. That's called isovolumetric because although the ventricles are contracting, they're not ejecting blood yet. So it's the same volume, isovolumetric. Cardiomyocytes exert force, but with all 4 valves closed, the blood can't go anywhere. Finally, pressure exceeds atrial pressure and the semilunar valves open. Pressure peaks in the left ventricle at about 120 millimeters mercury and 25 millimeters mercury in the right. At first, we have rapid ejection. The blood spurts out of the ventricles, and then reduced ejection. Ejection lasts about 200 to 250 milliseconds, corresponds to the plateau phase of the cardiac action potential. T wave of the ECG occurs late in this phase. Stroke volume is the amount ejected. It's about 70 mils, and it's as a percentage of EDV, the ejection fraction. That's about 54%. 60 mils remaining blood is the end systolic volume. Isovolumetric relaxation, the T wave ends and the ventricles begin to expand. Blood from the aorta and pulmonary trunk briefly flows backward, filling the cusps and closing the semilunar valves, creates pressure rebound that appears as dicrotic notch in the graph of the artery pressure. The heart sound S2 occurs to prevent blood from flowing back into the heart. So that's the closing of those semilunar valves. It's called isovolumetric because semilunar valves are closed and the AV valves have not yet opened, so no change in blood volume. When the AV valves open, ventricular filling begins again. Duration of systole in a resting person lasts about 0.1 seconds. Ventricular systole is about 0.3 seconds. There's a quiescent period when all 4 chambers are in diastole that lasts about 0.4 seconds. Total duration of the cardiac cycle is therefore 0.8 seconds in a heart beating 75 beats per minute. This is where you will have to review carefully this diagram and kind of correlate for yourself what is happening during each step of the cardiac cycle. I do have a really great resource that I provided that allows you to click through and visualize how the heart is changing size and everything, but this is another great diagram that you can review. Congestive heart failure results from the failure of either the ventricle to eject blood efficiently, usually due to heart weakened by myocardial infarction, chronic hypertension, valvular insufficiency, or congenital defects in the heart structure. Left ventricular failure, blood backs up into the lungs, causing pulmonary edema, shortness of breath, and sense of suffocation. Right ventricular failure, blood backs up into the vena cava, causing systemic or generalized edema, enlargement of the liver, ascites, or pooling of fluid in the abdominal cavity, distension of the jugular veins, and swelling of the fingers, ankles, and feet. Ventricular output, so you see right ventricular output exceeds left ventricular output, pressure backs up, fluid accumulates in the pulmonary tissue. Left ventricular output exceeds right ventricular output, pressure backs up, and fluid accumulates in systemic tissue. So you can tell whether it's right ventricular failure or left ventricular failure. Heart rhythm and contraction are controlled by two cardiac centers in the medulla oblongata. Cardioacceleratory center communicates with the heart via the right and left cardiac nerves, carrying sympathetic postganglionic nerve fibers. Cardioinhibitory center communicates with the heart via the right and left vagus nerves, carrying parasympathetic preganglionic nerve fibers. Sympathetic pathway is going to increase the heart rate. Parasympathetic pathway stops the increase and allows the heart to go back to the normal firing of the SA node. And here's a diagram of those pathways. Cardiac output. So cardiac output is an important number that's calculated to determine the heart health of individuals, especially individuals that are at high risk of myocardial infarction. Cardiac output is the amount ejected by each ventricle in 1 minute. Cardiac output is equal to the heart rate times the stroke volume. Thus, the body's total volume of blood passes through the heart every minute. Cardiac output varies with activity. Vigorous exercise increases cardiac output for a fit person and up to more than 40 for a world-class athlete. Cardiac reserve is the difference between a person's maximum and resting cardiac output. Those with heart disease may have little reserve and little tolerance for exertion. Heart rate is measured by taking a pulse, a pressure surge, at a point where the artery runs near the surface. The radial artery near the wrist is the common one to use. We can also use the common carotid artery in the neck. Infant heart rate is approximately 120 beats per minute. Young adult females 72 to 80, young adult males 64 to 72, rises again in the elderly. Variations in heart rate: tachycardia is too high, bradycardia is too low. Positive chronotropic agents, factors that raise heart rate, and negative chronotropic agents are factors that lower heart rate. Sympathetic postganglionic fibers are adrenergic. They release norepinephrine, and the adrenal medulla secretes norepinephrine and epinephrine, which bind to beta-adrenergic receptors in the heart. They activate cyclic AMP, second messenger system, in cardiomyocytes and nodal cells, leading to the opening of calcium channels in the plasma membrane. Increased calcium flow accelerates depolarization of the SA node. By accelerating both contraction and relaxation, norepinephrine increases the heart rate as high as 230 beats per minute. At excessively high heart rates, diastole becomes too brief for adequate filling, so both stroke volume and cardiac output are reduced. Parasympathetic acetylcholine binds to muscarinic receptors, which opens potassium gates at nodal cells. So typically, acetylcholine is a stimulatory neurotransmitter for muscles. But in the case of heart muscle, norepinephrine increases the heart rate, while parasympathetic acetylcholine decreases the heart rate. In addition to the sympathetic and parasympathetic nerve fibers that can have some impact on heart rate, there's pressure receptors that can also have impact on heart rate. So proprioceptors in the muscles and joints inform cardiac centers about changes in activity. Heart rate increases before metabolic demands on the muscle arise. Baroreceptors or pressure receptors, pressure sensors in the aorta and internal carotid arteries, send signals to the medulla regarding blood pressure, so the heart rate can adjust accordingly. Baroreflex occurs to maintain homeostasis. If the blood pressure decreases, the heart rate increases, and vice versa. So blood pressure and heart rate are inversely related. Chemoreceptors can detect chemical stimuli like pH, carbon dioxide, and oxygen in the aortic arch. Chemoreflex occurs to maintain homeostasis. If we have too much carbon dioxide, we are going to increase the heart rate and increase tissue perfusion to get that carbon dioxide out. Autonomic neurotransmitters, we already talked about. Blood-borne adrenal catecholamines are potent cardiac stimulants. Nicotine stimulates catecholamine secretion. Thyroid hormone increases the number of adrenergic receptors on the heart, so it's more responsive to adrenergic stimulation. Caffeine inhibits cyclic AMP breakdown, prolonging the adrenergic effect. Electrolytes have a strong influence. Potassium has the greatest chronotropic effect. Potassium diffuses into cardiomyocytes. Myocardium is less excitable, and the heart rate becomes slow and irregular. Hyperkalemia, too much potassium, the cells hyperpolarize and require increased stimulation. Hypercalcemia, excess calcium decreases the heart rate and contraction strength. Hypocalcemia, a deficiency of calcium, increases the heart rate and contraction strength. As a side note, potassium injections are often used as a means of euthanasia. So especially in animals and birds, they will do a direct injection of potassium right into the heart muscle tissue, and it'll stop the heart. So we talked about heart rate and how heart rate can be influenced. Now we're going to talk a little bit about stroke volume and ionotropic agents. So the other factor in cardiac output besides heart rate is stroke volume. 3 variables govern stroke volume: preload, contractility, and afterload. Preload is the amount of tension or stretch in ventricular myocardium immediately before it begins to contract. It's summarized by the Frank-Starling law of the heart. Stroke volume is proportional to the end diastolic volume, and the ventricles eject as much blood as they receive. Example includes increased venous return, increases preload stretch, so the ventricles eject more blood. If they can stretch more, and they contract more blood out of the heart. Contractility refers to how the myocardium contracts for a given preload. Positive ionotropic agents increase contractility. Negative ionotropic agents decrease contractility. Calcium, norepinephrine, glucagon, and digitalis are examples of positive ionotropic agents. Hyperkalemia, or excess potassium, has negative ionotropic effect. Vagal stimulation have negative ionotropic effect on the atria. Ventricles are not innervated. And then afterload, the sum of forces a ventricle must overcome before it can eject blood. Blood pressure in the aorta, pulmonary trunk is the most significant contribution to afterload. Hypertension, atherosclerotic plaques are factors that increase afterload. The right ventricular failure due to obstructed pulmonary circulation is called cor pulmonale, common complication of lung disease like emphysema and chronic bronchitis. This diagram does a really good job at summarizing those factors that affect cardiac output. Test questions can definitely come from this diagram, so please take a look and make notes on these different aspects. This is basically a summary of the last few slides that we just went through. Exercise and cardiac output. So exercise makes the heart work harder and increases cardiac output. Proprioceptors signal cardiac center. At the beginning of exercise, signals from the joints and muscles reach the cardiac center of the brain. Sympathetic output from the cardiac center increases cardiac output. Increased muscular activity increases venous return and increases preload and ultimately cardiac output. Increases in heart and stroke volume cause an increase in cardiac output, so exercise produces ventricular hypertrophy. Increased stroke volume allows the heart to beat more slowly at rest. Athletes with increased cardiac reserve can tolerate more exertion than a sedentary person. Coronary artery disease. It's a degenerative disease in which the coronary artery is usually resulting from atherosclerosis, an accumulation of lipid deposits in necrotic tissue that obstructs the lumen and may cause a heart attack. Onset, progression, and outcomes. So hypertension or high blood pressure, diabetes, smoking, and other risk factors damage the inner lining or endothelium of the arteries. Myocytes adhere, penetrate the wall of the vessel, and become macrophages. Macrophages and smooth muscle cells absorb cholesterol and fat, become frothy, foamy cells that form yellow fatty streaks. The fatty streaks have the potential to progress into life-threatening atheromas, plaques. Alternatively, damaged vessels can scar and accumulate calcium. Arterial sclerosis, or hardening of the arteries. Risk prevention and treatment. So risk is associated with the amount of cholesterol that you have in the blood. LDL is the lipoprotein or low-density lipoprotein that transports cholesterol from the liver to be deposited in your tissues. HDL, or high-density lipoprotein, is the lipoprotein that transports cholesterol from the tissues back to the liver to be broken down. So we typically want to have more HDL and less LDL. If we have high LDL, that means we've got a lot of these transporters that are trying to shove more and more cholesterol into our tissues. Triglycerides are another one. So if we have a lot of fats floating around in the bloodstream, those triglycerides, typically due to obesity, that can be an issue that can attribute to this. Smoking, lack of exercise, stress, hypertension, all sorts of commonly known risks. CAD, often treated with coronary artery bypass graft, sections of a vessel are used to construct a detour around the obstruction in the coronary artery. Balloon angioplasty is another treatment. Catheter is threaded to the coronary artery and inflated and pressed and flattened in the atheroma against the arterial wall. In laser angioplasty, the atheroma is vaporized with a laser. Angioplasty is less risky than CABG, but atheromas may grow back. So these are some pictures of that you can take a look at. And then we're going to move on. So arteries, arterial sense organs in the walls of some major vessels, sensory structures, monitor blood pressure. Sorry about that. Let me fix the view because it looks like it's running off the page. Monitor blood pressure and chemistry. Transmit information to the brainstem to regulate heart rate, blood vessel diameter, and respiration. The carotid sinuses, there's baroreceptors in the walls of internal carotid artery. They monitor blood pressure, transmit signals through the glossopharyngeal nerve, and allow for baroreflex. So carotid bodies, oval bodies near the branch of the common carotids. Their chemoreceptors monitor blood chemistry, transmit signals through the glossopharyngeal nerve, the brainstem, and respiratory centers, adjust respiratory rate to stabilize pH, CO2, and O2. The aortic bodies are one of 3 chemoreceptors in the walls of the aortic arch. Same structure and function as the carotid bodies, but innervation is by vagus nerve. So this is the diagram of where those are located. Blood pressure, resistance, and flow. The blood supply to a tissue is expressed in terms of flow and perfusion. Flow is the amount of blood flowing through an organ, tissue, or blood vessel in a given time. It's expressed in milliliters per minute. Perfusion is flow per given volume or mass of a tissue in a given time, mils per 100 grams per minute. At rest, total flow is quite constant and is equal to the cardiac output. Hemodynamics, the physical principles of blood flow based on pressure and resistance. The greater the pressure difference between 2 points, the greater the flow. The greater the resistance, the less the flow. Blood pressure is the force that the blood exerts on a vessel wall. It's measured at brachial artery using sphygmomanometer, a close approximation of pressure at an exit of the left ventricle. So there's 2 pressures that are recorded. Systolic pressure, it's the peak arterial blood pressure taken during ventricular contraction or ventricular systole. So when the ventricles contract and the ventricles pump blood out of the heart, that highest pressure that it's going to be able to pump the blood out initially, that's systolic pressure. Then the ventricles are going to start to relax. The lowest pressure that the blood gets in those blood vessels, that's diastolic pressure. So it's the minimum arterial blood pressure taken during ventricular relaxation between heartbeats. So blood is always going to flow through at some type of pressure, but the lowest pressure that can be recorded is the diastolic pressure. Normal blood pressure for a young adult is 120/75. Pulse pressure is the difference between the systolic and diastolic pressure, important measure of the driving force on circulation and of stress exerted on small arteries by pressure surges generated by the heart. Mean arterial pressure is this diastolic pressure plus 1/3 of the pulse pressure. Average blood pressure that most influences the risk level for edema, fainting, also known as syncope, atherosclerosis, kidney failure, and aneurysm. Since pressure varies across the cardiac cycle, blood flow in arteries is pulsatile. Speed surges from 40 to 120. Blood spurts intermittently from an open artery. In capillaries and veins, blood flows at a steady speed. Bleeding from veins tends to be slow and steady. So when you're taking blood from a patient, you can kind of know if you accidentally stuck an artery versus a vein, because if the blood is spurting into the blood tube, it's typically going to be an artery. Also, the blood is bright red in color if it's coming from the arterial side of things. Now, there are some instances when we need to collect arterial blood, but most of our blood work is drawn using blood from veins. Blood pressure tends to rise with age. Arteriosclerosis, stiffening of arteries due to deterioration of the elastic tissues of the artery walls, and atherosclerosis is the buildup of lipid deposits that become plaques. So this is a diagram that shows the changes in blood pressure relative to distance from the heart. So obviously the farther away, the lower the pressure. Hypertension, chronic resting blood pressure higher than 130/80. It can weaken arteries and cause aneurysms or promote atherosclerosis. Hypotension, chronic low resting blood pressure, caused by blood loss, dehydration, anemia. No specific numerical criterion for hypotension. Blood pressure is determined by 3 variables: cardiac output, blood volume, and resistance. Blood volume is mainly regulated by the kidneys. Except for beating of the heart, kidneys have the largest influence on blood pressure of any organ, over any organ. Peripheral resistance, the opposition to flow that the blood encounters in the vessels away from the heart. Resistance hinges on 3 variables: blood viscosity, or the thickness of the blood. If we were to try to pour syrup through a hose versus water through a hose, the syrup, which is more viscous, would not flow as much through, so it would have more resistance. Vessel length, the longer the vessel, the more resistance. And vessel radius, so the bigger the radius, the lower the resistance. And this just kind of summarizes that. So again, blood viscosity stems mainly from plasma proteins. If you're dehydrated, your blood can become a little bit more viscous. Low red blood cells, or albumin, reduces viscosity and speeds up blood flow. High viscosity and flow declines with polycythemia and dehydration. Vessel length, the farther liquid travels, the more cumulative friction it encounters. Pressure and flow decline with distance. And then vessel radius, the greatest control over blood flow. Blood flow is proportional to the 4th power of the radius. Small changes in radius results in large change in flow. Allows for the control of resistance movement from movement to movement. Blood exhibits laminar flow in layers, and dilating a vessel allows more blood to flow without friction of the vessel wall. Vasomotion, collective term for vasoconstriction, narrowing of the vessel, and vasodilation or widening of the vessel. So this shows dilated, vasodilation, vasoconstriction. Peripheral resistance from aorta to capillaries, blood velocity speed decreases for 3 reasons. The blood has traveled a greater distance, smaller radii, or the number of vessels in their total cross-sectional area becomes greater and greater. Since veins are larger, they create less resistance than capillaries. Large amount of blood forced into smaller channels. Blood in veins never regains velocity, and it had in the large arteries. The veins are further from the pumping heart, and veins are more compliant. They stretch more than the arteries. Arterioles are the most significant point of control over peripheral resistance and flow on the proximal side of the capillary beds, and best positioned to regulate flow into the capillaries. Outnumber any other type of artery, providing the most numerous control points. More muscular in proportion to their diameter, highly capable of changing the radius, and arterioles produce half the total peripheral resistance. Regulation of blood pressure. So there's 3 ways we can control vasomotor activity: local control, neural control, and hormonal control. So local control, autoregulation, the ability of tissues to regulate their own blood supply. If a tissue is inadequately perfused, wastes accumulated stimulate vasodilation, which increases perfusion. Vasoactive chemicals, substances secreted by platelets, endothelial cells, and perivascular tissues to stimulate vasomotor responses. Occurs during conditions of trauma, inflammation, exercise. Vasodilators include histamine, bradykinin, and prostaglandins. Reactive hyperemia, if the blood supply is cut off and then restored, flow increases above normal, maybe due to accumulation of metabolites during the period of ischemia. Angiogenesis, the growth of new blood vessels, allows a hypoxic tissue to increase its own perfusion. Neural control, so there's barrel reflexes, chemoreflexes, and the medullary ischemic reflex that can contribute to the neural control of blood vessel diameter. Barrel reflex has to do with pressure. So if the pressure sense receptors in various parts in the carotid sinus or other parts of the body sense that blood pressure is too high, it can cause the dilation of the blood vessels. If the blood pressure is too low, it can cause constriction of the blood vessels. And this is a diagram that you can kind of follow along with the different pressure regulations. Chemoreflex responses to changes in blood chemistry, especially pH and concentrations of oxygen and carbon dioxide. Chemoreceptors include aortic bodies in the aortic arch and subclavian arteries and carotid bodies in the external carotid arteries. Primary role is to adjust the respiration in changes to blood chemistry. Secondary role is vasomotion. The medullary ischemic reflex, automatic response to drop in perfusion of the brain. The medulla oblongata monitors its own blood supply. Ischemia triggers corrective reflexes. Then we have hormonal control. Angiotensin II. We will go back and review these when we talk about the regulation of fluid balance by the kidneys. But angiotensin II is a potent vasoconstrictor that raises blood pressure. The synthesis of angiotensin II requires angiotensin converting enzyme, or ACE. Hypertension is often treated with ACE inhibitors, which block production of angiotensin II, lowering the blood pressure. Aldosterone promotes sodium retention by the kidneys. Sodium increases water retention as well. So if we retain more sodium, more water stays in the body, and ultimately that's going to increase our blood volume, which increases our blood pressure. Natriuretic peptides, those are secreted by the heart. They increase sodium excretion by the kidneys. Water passively follows, which reduces blood volume and pressure. There's a vasodilating effect too, so natriuretic peptides are going to decrease blood pressure. Antidiuretic hormone promotes water retention and raises blood pressure. At pathologically high concentrations, it also acts as a vasoconstrictor, hence its alternative name, arginine vasopressin. Epinephrine and norepinephrine, adrenal, and sympathetic catecholamines bind to alpha adrenergic receptors on smooth muscle of most vessels, stimulates vasoconstriction, and raises blood pressure. Vasomotion serves two purposes: generalized raising or lowering of the blood pressure, or selectively modifying perfusion of an organ or rerouting blood from one region to another. Generalized increase in blood pressure is important in supporting cerebral perfusion during dehydration or hemorrhage. Rerouting of blood, either centrally or locally controlled. Examples would be during exercise. Sympathetic system reduces blood flow to the kidneys and digestive tract and increases blood flow to the skeletal muscles. If a specific artery constricts, the pressure downstream drops, pressure upstream increases, and blood flows down a path of least resistance, allows for the rerouting of blood according to the needs of the body. Examples: while dozing in an armchair after a meal, vasoconstriction in vessels lower to the lower limbs reduces blood flow there, while vasodilation to the digestive organs increases local blood flow. And this is a diagram of those changes, and a graph that you can review. Capillary exchange, the two-way movement of fluid across capillary walls, allows exchanges to occur between the blood and surrounding tissues. Chemicals pass through capillary walls by three routes: endothelial cell cytoplasm, intercellular clefts, or filtration of pores, fenestrated capillaries. Mechanisms involved would be diffusion, transcytosis, filtration, and reabsorption. These should be a review from general EMP. Diffusion is the most most important form of capillary exchange. Glucose and oxygen diffuse out of the blood. Carbon dioxide and other waste diffuse into the blood. Capillary diffusion can only occur in two situations. Endothelial cell membrane is permeable to the solute. Solute can find passages large enough to pass through. Transcytosis is a vesicle-mediated transportation. Material is picked up on one side of the membrane by pinocytosis or receptor-mediated exocytosis, and transport vesicles move material across the cell. And these are the pictures of those processes. Fluid filters out of the arterial end of a capillary and osmotically re-enters the venous end, is reabsorbed, delivers materials to the cells, and then removes metabolic wastes. Balance between osmosis and hydrostatic pressure. Hydrostatic pressure drives fluid out of the capillary, high on the arterial end of the capillary, low on the venous end. Colloid osmotic pressure draws fluid into the capillary, results from plasma proteins or albumin, which are more plentiful in the blood. Onconic pressure is the net COP, blood COP minus the tissue COP. At the arterial end, the balance of hydrostatic and onconic pressures results in a net filtration pressure. At the venous end, it's the net reabsorption pressure. So this is what causes fluids to leak out of the capillaries from the arterial side and back into the capillaries on the venous side. And this is a diagram of those pressure changes. Capillaries usually reabsorb most of the fluid they filter. It's different in certain locations though, like the glomeruli of the kidneys. They are devoted to filtration. Alveolar capillaries in the lungs are devoted to absorption. Can vary from movement to movement, so resting tissue versus active tissue. Resting tissue, most precapillary sphincters are constricted. Active tissue, capillary pressure rises, filtration dominates. Edema is an accumulation of excess fluid in a tissue. The fluid filters into tissue faster than it's absorbed. Three primary causes. We could have increased capillary filtration, reduced capillary reabsorption, or obstructed lymphatic drainage. So we're having more stuff leak out of the capillaries, less stuff being reabsorbed back into the capillaries, or less stuff being reabsorbed into the lymphatic system. Pathological consequences of edema, tissue death, pulmonary edema, cerebral edema, severe edema can cause circulatory shock. Venous return, the flow back to the heart, is achieved by 5 mechanisms: pressure gradient, gravity, skeletal muscle pump, thoracic pump, and cardiac suction. And this just kind of goes through some of those details. We won't get too much into these details as we go through these slides. You don't need to know all the details of how blood is returned back to the heart. You just need to know the main names of what the 5 mechanisms are. Circulatory shock, any state in which cardiac output is insufficient to meet the body's metabolic needs. All forms of circulatory shock fall into 2 categories. Cardiogenic shock, inadequate pumping of the heart, usually results of myocardial infarction. Low venous return shock, cardiac output is low because little blood returns to the heart. Hypovolemic shock, loss of blood volume due to trauma, burns, or dehydration. Obstructed venous return shock, tumor or aneurysm compresses a vein and then impedes its blood flow. Venous pooling shock, large periods of standing, sitting, widespread vasodilation. Neurogenic shock results from a sudden loss of vasomotor tone and vessels dilate. Possible causes are brainstem trauma and emotional shock. Other types, septic shock, are due to bacterial toxins, and anaphylactic is due to an allergy. Compensated shocks, severe homeostatic mechanisms bring about spontaneous recovery. Decompensated shock, when compensation fails, life-threatening positive feedback loops occur. The brain, total blood flow to the brain fluctuates less than that of any other organ. Seconds of deprivation can cause loss of consciousness. 4 to 5 minutes causes irreversible brain damage. Brain regulates its own blood flow through mechanisms that we previously described. Poor perfusion leads to carbon dioxide accumulation in the brain. Low carbon dioxide in the brain, though, leads to the opposite result. pH increases, stimulates vasoconstriction, occurs with hyperventilation, and may lead to ischemia, dizziness, and syncope. Transient ischemic attacks, brief episodes of cerebral ischemia caused by spasms of decreased cerebral arteries, dizziness, vision loss, weakness, paralysis, headaches, aphasia, lasts from a moment to a few hours, often early warning of impending stroke. And a stroke, also known as a cerebral vascular accident, a sudden death of brain tissue caused by ischemia, can be caused by atherosclerosis, thrombosis, a ruptured aneurysm. Effects range from unnoticeable to failure or fatal. Recovery depends on the severity. Arterial pressure points can be used to either take pulse or they can be used to stop bleeding that's distal to that area. Hypertension is chronic high blood pressure. Major cause of heart failure, stroke, and kidney failure. Damages by increasing afterload. Myocardium enlarges, so we have an enlarged heart. Strains blood vessels, tears endothelium, which becomes focal points for further atherosclerosis. Primary hypertension results from complex combination of behavioral, hereditary, and other risk factors. Secondary hypertension results from other identifiable disorders like kidney disease, atherosclerosis, hyperthyroidism, Cushing's syndrome, or polycythemia. Most of the cases are primary hypertension.